On May 21st, 2026, 2 days ago, Eli Lilly released the TRIUMPH-1 Phase 3 results. 30.3%. That is the average body weight lost by participants on the highest dose at 104 weeks. That is 85 pounds. That is 2 years of treatment. And that number has never been achieved by a drug before. For context, a 30% weight loss has historically been achievable only through bariatric surgery, gastric bypass, sleeve gastrectomy, procedures that permanently restructure the anatomy of the stomach. A pill-free once-weekly injection just matched that threshold. This episode is a complete breakdown of what the TRIUMPH-1 data actually says, the numbers, what they mean, what the trial design tells us, and the honest questions that remain before this drug reaches patients. TRIUMPH-1 is the largest and longest Retatrutide Phase 3 trial to report results so far. 2,339 participants, randomized, double-blind, placebo-controlled, adults with obesity or overweight, defined as BMI of 27 or above, with at least one weight-related comorbidity, but without type 2 diabetes. Comorbidities included cardiovascular disease, hypertension, dyslipidemia, and obstructive sleep apnea. This is not a healthy population handpicked to produce good numbers. This is a realistic clinical population, the kind of patients who would actually be prescribed this drug. And 3 active doses were tested, 4 milligrams per week, 9 milligrams per week, and 12 milligrams per week. All 3 began at 2 milligrams and escalated every 4 weeks to the target dose. The primary endpoint was percentage weight loss at 80 weeks. A pre-specified extension study continued to 104 weeks for participants with BMI 35 or above. All 3 doses met the primary and all key secondary endpoints, every single one. Quote from Anya Jastreboff, lead investigator at Yale. Obesity is a chronic disease, and people living with obesity deserve treatment options that match the complex biology of their neurometabolic disease. Let's go through the weight loss results dose by dose because the pattern across doses tells us something important. At 4 milligrams per week, the lowest dose reached with only a single escalation step, participants lost an average of 47.2 pounds. That is 19% of body weight over 80 weeks. Stop there for a moment. The lowest dose of this drug produces 19% weight loss. That is already competitive with the approved dose of Ozempic for obesity at the lowest, simplest, fastest to reach dose at 9 milligrams. Participants lost an average of 64.4 pounds. That is 25.9% of body weight. At 12 milligrams, participants lost an average of 70.3 pounds. That is 28.3% of body weight over 80 weeks. And in the pre-specified extension, participants with BMI 35 or above on 12 milligrams continued to lose weight through 104 weeks, reaching an average of 85 pounds lost. 30.3% of body weight. The placebo group lost an average of 2.2%. The drug effect is real, large, and dose dependent. But the most striking number in the entire data set is this one. 45.3% of participants on the 12 milligram dose achieved 30% or greater weight loss by week 80, and 65.3% of the 12 milligram group had a BMI below 30, the clinical threshold for obesity, by week 80. 2/3 of participants no longer met the criteria for obesity. To understand what these numbers mean, you need to see them against the existing landscape. Ozempic, semaglutide, 2.4 milligrams weekly, produced approximately 15% average weight loss in the Step 1 trial at 68 weeks. That was the number that made it a blockbuster. That was the number that launched a cultural moment around GLP-1 drugs. Mounjaro and Zepbound, Tirzepatide, dual GLP-1 and GIP agonists, produced approximately 22% average weight loss at 72 weeks in the SURMOUNT-1 trial. That was the step change that made everyone reconsider what was possible. Retatrutide at 12 milligrams, 28.3% at 80 weeks, and 30.3% at 104 weeks. Each step in this progression represents a genuine, meaningful clinical improvement. The difference between 15% and 22% is real for patients. The difference between 22% and 28.3% is real. And the difference between a drug that produces 22% and a drug where 45% of patients achieve 30% or more. That gap is the size of bariatric surgery. Bariatric surgery, gastric bypass, produces approximately 25 to 35% excess weight loss long-term in most studies. The high responders to retatrutide at 12 milligrams are now in that same range without surgery, without anatomical restructuring, once a week. That is the clinical significance of these numbers. Weight loss is the headline number, but TRIUMPH-1 reported a complete cardiometabolic picture alongside it, and those numbers matter as much as the weight data for anyone thinking about this drug's real-world significance. Waist circumference reduction, an average of 24.1 centimeters at 80 weeks on 12 milligrams. This is visceral fat, like the metabolically active fat around the organs that drives cardiovascular risk. 24 centimeters is a transformative reduction. Non-HDL cholesterol, significant reduction. Non-HDL cholesterol is the lipid marker most predictive of cardiovascular events. It captures all the atherogenic lipoproteins, not just LDL triglycerides. Significant reduction. Elevated triglycerides are an independent cardiovascular risk factor, particularly relevant in obesity. Systolic blood pressure, significant reduction. Blood pressure reduction in this population directly translates to reduced heart attack and stroke risk. High sensitivity C-reactive protein, significant reduction. HSCRP is the inflammation marker. It is an independent predictor of cardiovascular events beyond cholesterol. Reducing it means reducing systemic inflammatory burden. This is the full picture of what retatrutide does metabolically. It is not just making people lighter. It is fundamentally shifting the cardiometabolic risk profile of the people taking it. That is why the cardiovascular outcomes trial, which is still running, is so important. If a drug reduces blood pressure, lipids, inflammation, and body weight simultaneously, the MACE outcomes data should be striking. There is a finding in the retatrutide data set that is not getting enough attention outside specialist circles. In June 2024, a phase 2 sub-study published in Nature Medicine examined retatrutide's effect on MASLD, metabolic dysfunction-associated steatotic liver disease. This is the condition formerly called non-alcoholic fatty liver disease. It affects an estimated 30% of all adults globally. There are very few effective treatments. In that sub-study, retatrutide reduced liver fat by approximately 86% in participants with MASLD. 86% reduction in liver fat. In people who responded to the drug, many had resolution of steatohepatitis, the inflammatory component of the disease, entirely. Phase 3 liver disease data from the TRIUMPH program are expected later in 2026. If those results replicate the phase 2 sub-study, retatrutide becomes not just an obesity drug, but potentially the most effective treatment available for a condition that currently has almost no good pharmacological options. That is a second indication that could independently justify this drug's approval, and separate from obesity entirely. Every trial produces a safety section, and TRIUMPH-1 is no different. Here is what the data actually shows. Adverse events were broadly consistent with what we know about the incretin class. Nausea, vomiting, diarrhea, and constipation were the most commonly reported events. This is the same profile seen with Ozempic and Mounjaro. It is a class effect concentrated in the dose escalation period. Discontinuation rates due to adverse events were dose dependent. 4 milligram group, 4.1% discontinued. 9 milligram group, 6.9% discontinued. 12 milligram group, 11.3% discontinued. Placebo group, 4.9% discontinued. And the 12 milligram discontinuation rate of 11.3% is higher than placebo, but lower than many comparable trials at equivalent or lower efficacy. The GIP component appears to be doing its tolerability work. Dysesthesia and abnormal skin sensation, typically described as tingling or numbness, was reported at higher rates than with Ozempic or Mounjaro. This appears to be a glucagon receptor class effect. It was generally mild and did not lead to high rates of discontinuation in most cases. The heart rate signal, dose-dependent increases in resting heart rate, consistent with glucagon receptor agonism. This is the same signal we covered in the previous episode, being actively monitored. The blood pressure reduction largely counterbalances it from a cardiovascular risk perspective. No unexpected safety signals were reported. TRIUMPH-1 is one trial in a program of 11. Here's where the full TRIUMPH program stands as of May 2026. TRIUMPH for obesity plus knee osteoarthritis, reported in December 2025. 28.7% weight loss at 68 weeks. 75.8% reduction in WOMAC pain scores already reported. TRIUMPH-1, the obesity with comorbidities, no diabetes, and reported May 21st, 2026. This episode, TRIUMPH-2, obesity with type 2 diabetes, results expected 2026. This will be important because the glucose lowering effect of Retatrutide through all three receptor pathways may produce different results in a diabetic population. TRIUMPH-3, obesity with established cardiovascular disease, results expected 2026. This is the trial that will answer the heart rate question in the highest risk cardiac population, the one we need. TRIUMPH-5, a comparator study in type 2 diabetes, benchmarking against an active comparator rather than placebo, expected 2026. Additionally, a dedicated MACE, major adverse cardiovascular events, outcomes trial is running through 2027 to 2028. This is the definitive cardiovascular safety and efficacy study. It will be the most important piece of data this drug produces after the weight loss results. FDA submission is now expected in late 2026. Approval, if granted, likely 2027. The phrase matching bariatric surgery has been used extensively in coverage of TRIUMPH-1. It deserves careful examination because context matters enormously here. Bariatric surgery, specifically Roux-en-Y gastric bypass, produces on average 25 to 35% total body weight loss over 2 years in most published studies, with the best outcomes in the 30 to 40% range for high responders. At 80 weeks, 45.3% of participants on Retatrutide 12 milligrams achieved 30% or greater weight loss. At 104 weeks, the average reached 30.3%. So is Retatrutide matching bariatric surgery? For the high responders, yes, in terms of the weight loss number. And that is genuinely unprecedented for a pharmacological agent. But bariatric surgery also has effects that go well beyond weight loss. Changes to gut anatomy, bile acid profiles, gut microbiome, and neuroendocrine signaling that produce metabolic improvements partially independent of weight loss. Surgery resolves type 2 diabetes in many patients at a rate that drugs have not yet matched. The comparison is useful but incomplete. What TRIUMPH-1 shows is that for patients who are not surgical candidates or who choose not to have surgery, there's now a pharmacological option that produces weight loss in the same numerical range for the first time. That is the clinical significance. Not that the drug is identical to surgery, but that the gap between medicine and surgery has closed to a point that changes clinical decision making. TRIUMPH-1 is the strongest phase 3 obesity drug data ever reported, and honest science requires asking what we do not yet know. First, durability. TRIUMPH-1 ran to 104 weeks for the extension cohort, but what happens at 3 years? At 5 years, the GLP-1 drug class has shown weight regain after stopping treatment. We do not know if Retatrutide's 3-receptor approach produces more durable loss. The MASLD outcomes trial will provide longer-term data, but dedicated long-term maintenance studies have not reported. Second, the cardiovascular disease population. TRIUMPH-3 has not reported until it does. Using Retatrutide in patients with established CVD requires caution. The heart rate signal in that population is genuinely uncertain. Third, cost and access. Retatrutide is not approved and has no price. But based on Zepbound pricing and GLP-1 market dynamics, expect a list price in the range of $800 to $1,200 per month in the US without insurance coverage. At that price point, the patients who need it most are often those who can afford it least. Fourth, the top line versus peer-reviewed distinction. Everything reported on May 21st, 2026 is top-line data. The company's announced headline results. Full peer-reviewed publication of the complete data set will follow, likely at the American Diabetes Association meetings in 2026. Top-line data rarely contains unexpected findings, but the full analysis may add nuance. Here is the honest verdict on TRIUMPH-1. This is the most significant phase 3 weight loss drug data ever published. 30.3% average weight loss at 104 weeks. 45% of patients achieving bariatric surgery level outcomes, complete cardiometabolic risk profile improvement, all 3 doses meeting all endpoints. The phase 2 data held and it was surpassed. So that the questions that remain are real: durability, cardiovascular populations, cost, and the peer-reviewed publication, but they do not diminish what TRIUMPH-1 shows. This drug works at a scale that changes what pharmacological treatment of obesity means. FDA submission is coming in 2026. If approved in 2027, Retatrutide will be the most effective weight loss drug ever approved. Full stop. Subscribe to Peptide Decoded. We will cover every TRIUMPH readout as it lands this year. TRIUMPH-2 diabetes data, TRIUMPH-3 cardiovascular data, and the full MACE outcomes trial. Drop a comment. Given the TRIUMPH-1 data, do you think Retatrutide will replace Mounjaro as the standard of care for obesity? We think yes. Tell us if you disagree.